Good morning. My name is Molly Piccione. I'm a third-year EMIM. I'm going to be presenting our EMCCM case and conference today. We'll start with a case. Oh, okay. This is a pre-hospital notification in CCT. A patient found on the ground next to her bed, responding only to painful stimuli, labored breathing, intermittent moaning, JVD, incontinent of feces. The vitals that were told to us over the phone were a BP of 180/129, a heart rate of 93 per minute, breathing at 38, satting 86% on room air with a finger stick of 106. A nasopharyngeal airway was placed and the patient was being bagged. A 3-lead EKG showed sinus rhythm, and our SpO2 improved to 100% with bagging. When this patient arrived in the CCT resuscitation bay, the airway was patent. There was a nasopharyngeal airway in place. Breathing was spontaneous but labored. The patient had cold extremities. The patient was incomprehensible. Her eyes were opening spontaneously, but she was unable to follow commands, and she had right gaze deviation. Her heart rate on arrival was 109 per minute, a respiratory rate of 30, hypertensive to 173/111, afebrile, saturating at 92% on room air, and a finger stick of 92. I'm going to ask a junior for a preliminary problem list. If anyone wants to volunteer. MJ, thank you for volunteering.
So preliminarily, altered mental status, there seems to be like a hypoxia, the right gaze deviation, possible stroke, hypertensive.
Yeah. So it's basically what we came up with. The patient was in respiratory distress, hypertensive and tachycardic, altered mental status, and the right gaze deviation. Initial interventions were IV access. The patient was intubated for a combination of airway protection and respiratory insufficiency. We used etomidate and rocuronium for this patient. Prior to intubation, she did become hypotensive. I don't remember how low her pressures dropped, but right after we intubated, we put in a femoral line. And then her pressure came back up all on its own, so she did not need to be started on pressors. Once her hemodynamics were stabilized, we called a stroke code in the CCT. Can I have a differential at this point from maybe a junior or a third year, if anyone wants to volunteer? Oh, Chief Warshaw, would you just throw out just one or two that you were thinking about?
Intracranial hemorrhage, seizures,
yeah,
coronavirus.
Yeah, all great ones, all very pertinent. Some of the primary neuro ones we thought of were stroke, trauma, seizure, subarachnoid hemorrhage, metabolic, something like a euglycemic DKA, hyponatremia, hypothyroid, uremia, or hepatic encephalopathy. Infectious origins like pneumonia, meningitis, sepsis, COVID, always. And then tox things like alcohol, opiate overdose, CO poisoning, or salicylate toxicity, and then trauma once again for good luck. She was sent to the CAT scanner.
You bring the mouse to the other screen. Yep. Great.
Transfer.
Yeah.
You just have to hover outside of it and then click.
We got a little bit more history at this point. This patient was found on the floor next to the bed by the home health aide. Her last known well was unknown. BLS found her minimally responsive with labored breathing, incontinence of feces, and cool extremities. And there was no additional information obtained in the ED. Her ECG is as follows. I'm going to ask Dr. Mazzio if you would give us some, so you don't have to go deep into depth on the EKG, just rate rhythm axis.
So rate's variable. Looks like it's a little on the tachycardic side, I'll say. Rhythm is irregular. Axis is normal.
Yeah, so this patient was in atrial fibrillation with a rate of around 88. The QTC read on the ECG machine said 527, calculated around 516. We got back a venous blood gas analysis at this point that was fairly unremarkable. The next set of tests and consultations were as follows. We ordered CBC, basic blood work, tox labs, type and screen, blood culture, chest x-ray, and then a neurosurgery consult based on our CT head findings. The results were as followed. Her CBC and comp were fairly unremarkable. She was thrombocytopenic with platelets of 52. Her INR was elevated to 1.3. And her chest radiograph was read as diffuse parenchymal opacities, multifocal pneumonia. She was, again, post-intubation. And you can see that, and some cardiomegaly. The CT imaging, the CT head and CTA the reads started coming back at this point. The CT head was read as right intraparenchymal hemorrhage involving the right thalamus, 3.1 by 2.2 centimeters, with surrounding vasogenic edema. Mass effect onto the right posterior horn of the lateral ventricle with complete effacement and mild mass effect onto the third ventricle. There was extension of the hemorrhage intraventricularly bilaterally, right greater than left. There was a mild hydrocephalus and no midline shift. CTA head and neck showed no stenosis, dissection, occlusion, or aneurysm, and CT max facial showed no fracture. Our updated problem list at this point, intraparenchymal hemorrhage, aspiration pneumonitis, thrombocytopenia, and uremia. The patient did become hypertensive again in the ED with a nicardipine drip. The patient was given DDAVP as she was uremic and on antiplatelet agent. As she was uremic. And then the consultation follow-up started coming in. Neurology stroke consult said DDAVP for thrombocytopenia, suggested an SBP goal of 140 to 160 with a nicardipine drip, and then repeat the CT head in 6 hours. Neurocrit care, suggesting admission to neuro ICU, and neurosurgery, correct coagulopathy, platelet goal of 150, INR of less than 1.2, and blood pressure control. Patient was given mannitol in the ED, and then was started on a propofol drip, and on hospital day 1 was transferred to the neuro ICU. The discussion today is going to be about spontaneous intracerebral hemorrhage. This is not meant to be a treatment guide. It seems like there are a lot more questions or answers for this particular neurocrit topic. I'm hoping that no matter where you are in your learning, you'll have a little bit more understanding of where we are in understanding some of these processes and why we do or do not do certain things. Our goals are as followed. One is to classify intracranial hemorrhage based on the neuroanatomy, because this is fairly important for prognostication and management. Understand which interventions do and do not have data to support them. And then 3, understand the morbidity and mortality of spontaneous intracranial hemorrhage. There is a very long list of things we're going to try to get through. Stop me if you have questions, but otherwise we're going to chug right through in under 60 minutes. We're talking a little about background, initial assessment, and then blood pressure management, hemostasis, anticoagulation, antiplatelet, seizure prophylaxis, management of ICP, surgical indications, and then prognosis and goals of care. In 2015, the American Heart Association and American Stroke Association put out joint guidelines for management of spontaneous ICP that largely informed the outline of this lecture. And so we'll go a little bit into the data based on their recommendations. For some background, spontaneous intracranial hemorrhage is the second most common cause of stroke behind ischemic stroke, which accounts for about 20% of the strokes that we see. 25% of these will be in the setting of oral anticoagulant use, and they are pretty deadly. They account for about 50% of the stroke-related deaths. Of note, in the 1990s, warfarin use doubled, and we saw a quintupling of spontaneous ICH related to anticoagulants. Risk factors for spontaneous ICH: hypertensive vasculopathy, cerebral amyloidosis, AV malformations, ruptured berry aneurysms, antithrombotic therapy, dual antiplatelet therapy, and possibly aspirin. There is mixed data on whether or not this actually increases your risk. Some less common things that can predispose are tumors, septic emboli, vasculitis, reversible cerebral vasoconstriction syndrome, thrombolytic therapy, and moya-moya disease. The pathogenesis is based on MRI neuroimaging. Suggests it is likely due to hyalinosis and amyloidosis, leading to microscopic pseudoaneurysms that have a very high bleeding risk. They rupture, they put pressure on the surrounding vessels, which are also very weak from amyloid and hyalinosis, and then those rupture as well. The mechanisms of injury are direct from the expanding clot, mixed with cytotoxic edema. And then there are secondary brain injuries where the mechanism is less well understood, but showing more diffuse breakdown of the blood-brain barrier. The The presentation is generally during routine activity. It can be gradual and progressive with neurologic symptoms occurring over minutes to hours, in contrast to an acute occlusive stroke that's going to come and hit, and you might see your most severe symptoms at the outset. Classically, you'll see headache, vomiting, decreased mental status, but they can really present with any neurodeficits. And the neurodeficits are going to be based on the area of involvement. Of note, stupor and coma are generally a very bad prognostic indicator, but if the patient's reticular activating system is what is being affected by this hemorrhage, you have disrupted their wakefulness, and so when the blood is absorbed or evacuated, they can actually have near complete resolution of symptoms. The location really matters for prognosis and pathogenesis. About 90% of what we will see is deep ICH, and this is where we see most of our hypertensive hemorrhage. This is in the basal ganglia, the pons, and the thalamus. Much less commonly, you will see lobar. Most of our lobar will actually be extension from the deep hemorrhage, but you should be thinking of other underlying causes when you see a primary lobar hemorrhage. Things like cerebral amyloid, AVM, bleeding into a tumor, hemorrhagic conversion of an ischemic stroke, and these have a higher rate of seizure. There are also cerebellar lesions, which are caused by hypertensive vasculopathy primarily, but are much less common. So the hemorrhage expansion most commonly happens in the first 24 hours. There's some evidence even saying the first 3 to 4 hours after injury. This is why the ED management is so important. Our goals are really to prevent expansion of hemorrhage and then prevent secondary brain injury, things like elevated ICP, herniation, seizure, and obstructing hydrocephalus. Our initial assessment, always ABCs. Our patient in our case was not well enough to even have a stroke code called until she was intubated and had a central line in place. CT head without contrast, as ischemic and hemorrhagic strokes are clinically indistinguishable. They can show hyperdense acute blood with edema, mass effect, and herniation. You should consider CTA or vessel imaging in the ED. This will help evaluate for underlying aneurysm or vascular malformation, help with surgical planning, and will help to prognosticate, and then pre-op labs. CTA can show something called a spot sign. You can get this hyperacute, you can get contrast extravasation into the hemorrhage you can see on CTA that has linked positively to hemorrhage expansion, and again, will help your neurocric team. The first thing that we're going to talk about in management is blood pressure control. This is a big topic of discussion that has been studied, at depth and is going to still continue to be studied for a long time to come. The AHA-ASA joint guidelines recommend that if the patient presents with a systolic blood pressure between 150 and 220, that the blood pressure should be acutely lowered to 140. This is safe and can be effective. And then just kind of say that if the blood pressure is greater than 220, the systolic pressure is greater than 220, it is reasonable to start IV pressure management. There are 3 big studies that I'm going to touch on briefly about where these guidelines come from. The first is the ATTACH-1 trial. This looked at patients with spontaneous ICH who presented with a systolic pressure less than 180, and said that you can acutely lower blood pressure, that if you acutely lower blood pressure to less than 140, it is safe. The second is the INTERACT-2 trial. This looked again at patients who came in with spontaneous ICH with a pressure less than 180, and showed that lowering pressure to less than 140 compared to 180 doesn't reduce the risk of death or severe disability, but there were long-term measures of disability that were better when you looked at a modified Rankin score. The third trial is the ATTACH-2 trial, and this included patients for the first time with systolic pressure above 220 for spontaneous ICH, and they showed there was no mortality benefit in receiving intensive blood pressure control compared to the less tightly controlled 140 to 180. The AHA-ASA kind of appropriately says this is safe and can be effective. There are a lot of studies that have been done looking at imaging, but there's still a lot of conflicting data about whether or not these are all patient-centered outcomes. There's MRI evidence that about 25% of patients with spontaneous ICH will at some point in the acute phase have an ischemic stroke. Whether or not that's clinically significant is not really clear. There's other like PET and advanced imaging that show there's decreased metabolic demand during this acute phase and decreased oxygen extraction fraction. So whether or not this is really focused on patient outcomes remains to be seen. Look at this through what's best for your patient. Dr. D'Souza wanted me to make a recommendation on whether or not you should lower the pressure below 140. I've been torturing myself for 3 weeks. I still don't really know if this is something that I have a recommendation on, but I guess it's a 5-year program, so I'll touch back in with you guys at some point.
I think it's really important to mention here in that we're not functioning in a silo. The neurointensivists are going to come down and they're going to say, you got to get the pressure below 140 because the guidelines say 120, 140 is what you need. Is there data to support that? Absolutely not. There's no data to support that number, but that's what the guidelines say. And so are you going to have a fight with the neurointensivist because they're going to come down and they're going to be like, you're going to be like resuscitating the patient, you're going to be intubating the patient, and they're going to be like, you got a low blood pressure, you got a low blood pressure, that's the only thing they want to talk about, and they're going to keep talking about the penumbra. You're going to, I don't want to interrupt too much, but yeah.
Dr.
I've asked this question of the neurointensivist, and it's devolved into hours of conversation to the point that my eyeballs were looking in different directions because I don't know, I still don't get a definitive answer, but it sounds like pushing it to this 140 versus if the person's coming in super hypertensive and maybe there's this history for the chart, if they're chronically living in hypertensive, maybe you could allow for a little bit on the higher side to avoid causing that ischemia. That's why they usually give that range of 140 to 160, sometimes even 140 to 180.
Yeah.
I also have a question. In this patient as well, they look like they're in a little bit of like cardiogenic shock or like some JDE, cold extremities.
Yeah,
any consideration for that and the blood pressure?
So we kind of followed what her blood pressure did. It did drop. She did seem to be like she was in a little bit of a hemodynamic compromise that seemed to have gotten better. And she was perfusing a little bit better. And then she started, as the rock wore off, she started to wake up a little bit. And so we didn't set her. Her goal was set between 140 and 160 to the best that I can understand. But she also didn't have an A line and an ED, so I don't know how tightly controlled. We could have gotten her to. For the people at home, Dr. Schechter pointed out that this is not something we operate on without neuro-crit, neurointensivist support. And Dr. Beta also pointed out that this is something of great debate. We can study at length without a definitive answer. The next thing I'm going to talk about is hemostatic agents. TXA and recombinant factor 7 have both been studied and shown to decrease the expansion of hematoma in spontaneous ICH. In contrast to that, there are some patient-centered studies that do not show the same benefit. The TISH2 study looked at using TXA and showed that there was no functional benefit or mortality benefit at 90 days, despite the fact that it did show a decreased hematoma expansion at day 2 and a decreased death rate at day 7. Recombinant factor 7 similarly showed decreased hematoma expansion, but doesn't improve survival or functional outcome. I was going to talk a little bit more about anticoagulant reversal, but Dr. Youssef is going to give a full 45-minute lecture on this. So thank you to Dr. Youssef. I will leave you with a few points next week, by the way. So I'll leave you with a few points, of things that are kind of food for thought on the topic of anticoagulation reversal. First is that normal coags do not eliminate the possibility of oral anticoagulant use. We don't routinely test for the things that would tell us if our patients are on these oral anticoagulants. The convention is that it takes 4 to 5 half-lives for elimination. So if a patient is being evaluated for ICH within 4 to 5 half-lives, of their last dose, they should still be assumed to have some on board. All of our direct oral anticoagulations require some amount of renal metabolism. So if your patient has renal impairment, you should also consider that 4 to 5 half-lives is not going to sufficiently eliminate for them. Most of these studies are based on laboratory evidence, not patient-centered outcomes. Even like the FFP versus PCC studies are really mostly done in vitro. And this is becoming the standard of care. So more on this next week. The next topic I'm going to talk about is antiplatelet management. Previously, there were recommendations to transfuse platelets in patients who are on antiplatelet therapy. The PATCH trial came out in 2018 that kind of disputed that practice. This was a multi-center RTC in the Netherlands, UK, France, and it enrolled patients with spontaneous ICH on antiplatelet agents and compared platelet transfusion versus no platelet transfusion. They found that the odds of death or functional dependence were 2 times more likely in the patients who did receive platelets. Of note, the study that was limited to only include patients with a GCS of 8 to 15. It excluded patients who were thrombocytopenic with platelets less than 100, and it excluded patients with surgery planned within 24 hours. This is to say, the American Association of Blood Banks doesn't create any sort of recommendation on this, even though they did put in some practice guidelines, but notes that the convention is to transfuse with platelets of 80 if there's planned neuraxial surgery. So if your neurointensivists and neurocrit team are planning for some sort of procedure in the next 24 hours, this is not the study to cite to say why you should not be giving platelets. I'm skipping those for time. Our goals in the ED are to prevent ICP elevation and prevent herniation. The normal ICP is 7 to 12, 15 millimeters of mercury. At around 20 millimeters of mercury, the brain loses its ability, it begins to lose its ability to auto-regulate and maintain fluid shifts and balance. And at around an ICP of 40, there's an increased risk of mortality. There's some very basic things that we can do in the ED. Head of bed to 30 degrees, avoid direct pressure of the neck veins and rotation of C-spine so that you're not impeding venous outflow, avoid hypotonic fluids, and you can consider some mild sedation or anxiolysis if your patient needs something for comfort. We can also use osmotic therapy. Traditionally, mannitol was favored, but there does seem to be a shift towards hypertonic saline. Wendy Chan, a former county grad, did a really good blog post in 2015 on the topic and based it on 3 meta-analyses comparing mannitol versus hypertonic saline. In a 2011 meta-analysis, the 2011 meta-analysis favored hypertonic saline to mannitol. It looked at RTCs comparing equiosmolar doses of mannitol to hypertonic saline for the treatment of elevated ICP, not specific to just spontaneous intracranial hemorrhage, but all ICP. And found a relative risk of pressure control of 1.16 favoring hypertonic saline, and that there was an average decrease of 2 millimeters of mercury favoring hypertonic saline compared to mannitol.
And you shouldn't give mannitol to dialysis patients. It's non-dialyzable, causes hyperkalemia.
Dr. Sinner is pointing out that we shouldn't be giving mannitol to dialysis patients because it is non-dialyzable and can cause hyperkalemia. The American Heart Association and American Stroke Association doesn't make any recommendations about even whether or not to use osmotic therapy, but does cite that hypertonic saline is likely more effective. In the 3 meta-analyses that I took a look at, it seems like hypertonic saline is more effective for treatment of ICP, elevated ICP, and also for refractory ICP. There do seem to be more patient-centered outcomes, like improvement in neurologic function and mortality benefits. But the side effects are different based on the 2 agents. Hypertonic saline can take quite a bit of fluid, so you can put the patient into fluid overload and can cause pulmonary edema. It also causes hypernatremia by design and can cause hyperchloremic metabolic acidosis. And compared to mannitol, which can cause a rebound increase in ICP, hypovolemia as it is an osmotic, and acute renal failure.
Did the guidelines mention the concentration, or they just blanket statement hypertonic?
Sophia's asking if the guidelines recommend what the treatment or how it's dosed. There was no recommendation even of whether or not they should be used.
They should be.
These are some of the guidelines or some of the suggested treatment plans, the 2 agents. I won't get too into depth on this because this is not really the purpose of this lecture. But for hypertonic saline, the goal sodium is somewhere between 145 to 155, and for mannitol, the goal serum osms between 300 and 310. ICP monitoring is not something that we do. Oh yeah, Dr. Willis.
Sorry, just a quick point. If access to either of these is an issue, bicarb pushes are another option that you could consider as well.
Dr. Willis is pointing out that if we have issues with access for these, we can also consider bicarb pushes to help manage ICP.
Another thing is between the hypertonic and the mannitol, not to use mannitol if the patient is hypotensive. You mentioned earlier there's a brief episode of hypotension. And then the access point. So the 23.4% is very concentrated. If it's given through a central line, the 3% can be given through a peripheral. Obviously, if someone's crashing, you have one, probably probably not the deal breaker, but that's kind of by the book. And there's also 2% formulation. You wouldn't be giving them as a bolus, but if you continue infusion after the initial bolus.
ICP management, ICP monitoring is not something we routinely do in the ED, but it may be something that happens for your patient upstairs. There are no hard indications to say when the patient should have invasive monitoring, but it seems like the convention is in GCS less than 8 and either evidence of herniation or impending herniation. So there's no strong data to suggest there are improved outcomes by measuring invasively. You can also, patients can also be treated with CSF drainage. This is typically to treat hydrocephalus, either obstruction of CSF outlet by way of an EVD, ventriculostomy, or evacuation of the cerebellar hemorrhage. Seizure prophylaxis is something that you will see frequently either suggested for or not for your patient. There's about a 15% risk of seizure after after spontaneous ICH. It is much more common in lobar than lacunar infarcts. The AHA, ASA guidelines recommend against prophylactic use. If you see the patient seize, you should be starting them on antiepileptics, but they recommend against prophylactic use. This was based on a 2019 meta-analysis that looked at AED use for primary prevention of seizure in spontaneous ICH and showed there was not an improved neurological function during long-term follow-up. Having said that, these eight studies, only one of them was an RTC. 4 of them were with phenytoin and 1 was with valproic acid, which have largely fallen out of favor. Only 2 of them looked at used with levetiracetam, which is a much safer profile. And speaking with Dr. Feinberg kind of briefly about this, she does recommend using levetiracetam for seizure prophylaxis, specifically for if there is either a lobar or lobar extension, specifically if there is temporal lobe involvement, because those patients are at the highest risk of seizure.
Now, did you see anything on interventricular spread and seizures? Or in the past that that's a higher risk for seizure?
I didn't see anything about, no, Dr. Wills was talking about interventricular spread having an increased risk of seizure. I didn't come across anything that, it was only anything about it, just that once there was lobar involvement is where it was a little bit dicier.
I don't think I've ever had a patient once who somebody didn't recommend to give a seizure prophylaxis, despite me saying that there's no evidence to suggest its use or even recommendations, but it always gets recommended.
Yeah.
And you know, Percapra is a relatively benign medication. I sometimes will, depending on how passive aggressive I am that day, I will not or leave it.
Dr. Scheger is pointing out that we typically do get the recommendation for seizure, anti-seizure prophylaxis.
Dr. Zatopchi had a
He also
comment.
mentions that it's passive aggressive.
Oh, and he also mentioned that he is passive aggressive.
One of the interesting
Go ahead, Doc.
therapies that's studied actually in the intraventricular spread is TPA. If there's intraventricular bleeding, actually instilling TPA is a catheter, and it's kind of mixed results with that. It's interesting that you're giving TXA for the intraparenchymal bleed, but then you're considering giving TPA through a catheter for the clot in the ventricle. Mixed results.
Dr. Zatopchi?
Dr. Z, do you have a question for us?
He's on mute. Okay.
Okay.
Oh, I think he's on. Okay, go ahead.
Okay. So moving on to surgical indications, there's really no hard and fast surgical indication. This is really up to the discretion of your neurosurgeon. Largely, it kind of looks like the indications for cerebellar, or if you have a large bleed, neurologic deterioration, or brainstem compression. It seems like it's very controversial whether or not surgery is indicated for a lobar hemorrhage, and is generally looked at only for refractory elevated ICP. And as we discussed in CSF drainage, if there is a neurologic deterioration and then signs of obstruction or enlargement, that would be time to drain the CSF. There are 2 things, the 2 things that correlate very highly with bad prognosis are the size of the bleed presentation and the patient's neurologic status. For a patient who has a less than 30 ml bleed and a GCS of greater than 8, there's still about a 20% mortality at the 30-day mark. For larger bleeds with a worse GCS, GCS less than 9, there's about a 91% mortality at the 30-day mark. There are other markers of poor prognosis that include increasing ICH volume over the first 24 hours, which is why our management is so important. The deep location, anticoagulant use, and intraventricular extension. There are scores to prognosticate the likelihood of mortality, like the intracerebral hemorrhage score, which is a score of 1 to 6 that is used to predict the mortality associated with ICH. In the study that they based this score calculator on, it was a score of 1 to 6 points. 1 point suggested a 13% mortality, 2 points a 26% mortality, 3 points jumps up to 72% mortality, 4 points a 97% mortality, and a 100% mortality with 5 points. No one in the study actually had all 6 points based on age, ICH volume, intraventricular involvement, and GCS and area of involvement of brain. Despite all of that, the AHA and ASA recommends no new DNR orders in the first 24 hours for these patients. They cite the fact that none of our prognostications and none of our calculators account for DNR orders, and that by pulling back on aggressive care, we might be causing a self-fulfilling prophecy for the patients. They cite a couple of retrospective studies that really jump to some conclusions that their data doesn't support. But they all kind of say that if you account for the fact that we withdraw care, this might not be as deadly as you think. I don't know that this is an evidence-based practice so much as a professional, as a specialist recommendation. But you should consider aggressive guideline concordant therapy for all patients with spontaneous ICH, unless they come in with advanced directives that prohibit these things. In summary, there was a lot to go through in this topic, and I'm going to make my points kind of as succinct as I can. The first is that lowering systolic blood pressure to less than 140 is safe and may improve outcomes, but is probably not recommended if the presenting pressure is greater than 220. Hypertonic saline is slightly better for lowering ICP compared to mannitol. Seizure prophylaxis is not routinely recommended, except should be considered very strongly in lobar involvement. TXA or recombinant factor 7 are not supported by evidence at this time. Platelets should not be used for reversal of antiplatelet agents, but can be considered in thrombocytopenia. Reverse the anticoagulation that you can reverse. More on this next week. Consider aggressive care for all of these patients in the first 24 hours. And as always, the treatment should be guided and personalized for each patient based on their unique presentation. Thank you to the EMCCM committee, Dr. Sivan Nupane, Matt Behrens, and John Riggins, as well as Dr. Ian D'Souza, Ian Kim, Dr. Ray Beta, who's been giving me so much help. And also thank you to Dr. Sage Wiener and Robbie Allen, who I saw this case with, and they looked through and tried to help keep this presentation where it needed to be. Questions?
Molly, can I make a comment about the seizure issue?
Please.
Okay, excellent lecture. Thank you. This was a very hard and topic to cover, but you did a great job. There are two issues regarding seizure with intracranial hemorrhage. One that most people have been focusing on, as you mentioned, is seizure prophylaxis, which we do have enough evidence that it doesn't prevent long-term seizures, long-term epilepsy. It might, in short term, might prevent seizure, but in long term, it doesn't do anything. That's why it's falling out of favor. However, the main issue of what we should be focusing on in having patients with neurological insults, such as intracranial hemorrhage, developing seizure during in the ED. So this patient, the way the patient presented, it is very likely that because of his intracerebral hemorrhage, he was having also seizure or status epilepticus. Having any kind of neurological insults increases the chance of seizure and increases the chance of status epilepticus. And in patients with TBI or intracranial hemorrhage, it can increase the mortality and morbidity threefold. So it is, now we have more and more evidence that when you have someone with any kind of acute neurological insults, we should consider active seizure and we should order EEG on them to make sure that the secondary insult from, they're not experiencing secondary insults from seizure from a status epilepticus. So keep that in mind. If you have anyone with any kind of acute neurological insult, they are at high risk of status epilepticus or seizure, and we should order stat EEG for them. Thank you.
Thank you, Dr. Satachi. Dr. G.
Yeah, so is there any good studies for bringing down the pressure? I know the American Heart Association prefers nicardipine, but is there any head-to-head studies of labetalol versus nicardipine?
Truthfully, I didn't look too far into which agents, but Dr. Beta.
Labetalol, you'll be bolusing, you'll be doing whatever, 10, 20 bolus doses, and then presumably the blood pressure will have those spikes. You'll get a different curve versus starting an infusion, where I think you could just closely titrate and get up to that whatever dose of nicardipine that got them to the target, and then titrate back down. I looked this up once, and there wasn't a large RCT that I found that was comparing labetalol specifically, but from just management on an infusion basis, nicardipine seems to be a little bit more convenient.
It's just that sometimes in the ER, especially now in UHB, it's so much easier to give labetalol as a bolus than to have the nurses start a nicardipine drip.
You could always give the first bolus, and then if the blood pressure goes above that target, if you've met that target with one single bolus, you're kind of done there. They've met that endpoint. If the endpoint isn't met and it's requiring redosing of meds, either a second dose of labetalol or you're just starting an infusion.
And that's what most of us do, is give the first dose of bolus so we can get it fast. And then once it's not controlled, then switch to a drip so there's a little bit of time to get it while the pressure is already lower.
I guess exactly what I do. I give a push of labetalol. Well, I order the nicardipine and the push of labetalol at the same time. So they give them labetalol while they're waiting for the nicardipine to get set up.
And let's look at those no head-to-head studies you can use. Phenolpham, there's other drugs out there too. But I think nicardipine is the one that the ICU guys like the best, and that's what we're kind of used to. So the drug that's going to give you the best results is the one that you're used to.
Are there meds that you maybe want to avoid? Antihypertensive, maybe actually nitroglycerin, meds that are going to vasodilate and actually increase the ICP.
Nitroprusside.
Nitroprusside. The person comes in, they're looking clinically, well, it would, but
Just so hard to
meds to
control.
avoid.
So volatile.
Yeah.
Did you see anything on aggressive airway management for these patients? I feel like that's always a question we have to deal with.
I didn't research it. The question was about airway management during for spontaneous asphyxiation. I didn't take a deep dive into it.
I have if anybody's worked with me in the last few months where I've had several head leaks, I almost always send the patient CAT scan before intubating them. It's a little bit outside the realm of normal because we're always taught to secure the airway first. Most of these patients are bleeding. It's not an emergent intubation because usually they're bleeding on their own, right? If they're not breathing on their own, they're in big trouble. Probably nothing you're going to do is going to help them, and you should intubate them. But if they're breathing on their own, yes, they might not be completely protecting their airway. The amount of time, the CAT scan is really going to dictate your care for this patient. So I do the CAT scan and I intubate them as soon as they come back, and it significantly increases the throughput of the care that you can provide for them. Because when you intubate them, you're like, I think this person has a head leak. But you don't know, because you've had patients where you think they have head leaks and they end up not having head leaks. So you get the CAT scan, you're like, okay, now they have a head leak, let's intubate them, and we can do all the things that are needed. We can start their nicardipine drip, we can get their EVV placed, and it happens so much faster. You intubate them, great, you intubated them, but now they're on events, and getting a CAT scan can take 30 minutes to an hour. What, should it take that long? No, but it does. And so I always get the CAT scan first, and then I intubate them when they come back, and it worked out very well for me. I haven't had anything bad happen yet, and that's just my personal experience. I know it's a little bit outside the realm of what we do.
Another positive of that is people who are post-axial and just really abundant, they'll start to come back and you will save them intubation that they didn't need.
I guess the question is, what's your definition of things that require airway reduction, right? Like this patient had respiratory insufficiency.
That's a hard question. A lot of more experienced physicians will hold off longer because they have more faith in their abilities and they've just seen more. And I think the newer physicians will jump very quickly to intubate somebody, because it's easy to deal with somebody who's just intubated in the corner than it is to watch them and make sure nothing bad happens. But it all comes with your comfort level and how long you've been doing this for.
I think this patient should have been intubated. Yeah. Right? It was hypoxic, and I think the hypotension was probably due to hypercardia. I mean, you're looking at the whole picture, probably that episode of hypotension, peri-intubation was due to the patient hypoventilating.
This patient also vomited early in the presentation. It was another reason that we wanted to intubate her.
Yeah, this patient was not questioned.
I'm not talking about this patient.
Yeah, no.
I had a question. So this patient had COVID, right?
No.
No, that was an aspiration pneumonia.
I had aspiration pneumonia. Presumably.
Okay. So just my question is about glycemic control in the ER. Like if you have a patient with hyperglycemic, is there any benefit, mortality benefit, or prognostic benefit from controlling it's very secondary.
I don't know specifically if there's a mortality benefit with glucose control in like the ED. There is definitely benefit for glucose control. They've showed that poor hyperglycemia is linked very poorly to outcomes for these patients. So I think the convention is you want to get their sugar between 140 and 180. But I don't have any like specific studies to cite on the topic.
Google should match blood pressure.
Richard, was studied here for ischemic stroke, right?
What?
Wasn't it studied here for ischemic stroke?
Yes,
for
it didn't make a difference.
Yeah.
And we did attack 2 here too.
Quick question. Did you find any data on, I would usually give it nimodipine in the setting of a subarachnoid to prevent vasospasm?
I didn't look at subarachnoids at all.
Okay.
Because the data was old, it was like sort of falling out of favor.
They still recommend to give it.
For aneurysmal subarachnoid.
Yeah.
It's not. For aneurysmal subarachnoid.
Yeah, they say for trauma.
Yeah.
They want to give it.
Doesn't mean it's data.
Only subarachnoid.
No, for trauma, yeah.
Okay, there's a question on Zoom. Did you find any recommendations on modality of BP monitoring? Should we be placing A-lines in the ED?
I didn't look at the data for placing an A-line in the ED.
You know, I had this talk this last week in ICU. Is the arterial line going to be the next Swan Gans? You know, do we need continuous monitoring? I think it depends. I think it's how aggressive you're taking care of the patient. If you're using infusions that you want to titrate minute to minute, or how frequently are you programming in the monitor the non-invasive intermittent? If you're doing it every 3 minutes, you're going to have 3 minutes without data. You're going to lag behind 3 minutes. If you want continuous minute to minute with an infusion, then you have an A-line. But I've never actually seen anything that says supports you have an A-line.
Change mortality.
Yeah, it has a patient-centered outcome. So is it really and then if you're going to place an A-line, where are you going to place it?
DP.
What are you going to use as your accurate data measure?
Or South Beach.
All right, any other?
Right foot.
I think this is really good because the airway management, the blood pressure control, and the anticoagulant reversal are, I think, probably the highest yield upfront interventions that could package the patient. Either they did need airway management, their blood pressure goal is met with either the single dose labetalol, 2 doses, or an infusion started, and whatever is going to increase the risk of further expansion in the setting of the anticoagulant is reversed. I think, and then whether or not there's non-convulsive status to start AEDs. I think those are the upfront kind of time-sensitive interventions that are the most important to emphasize.
This patient's also a good candidate for propofol as their sedative. So that'll bring their pressure down and chill out their brain. So it's good all around.
That is what she got when she was when she had an infusion started.
I commend the care.
All right. Good job.
Great job.